Good afternoon, everyone. Thank you for joining us for our first of this series of Rural Health Clinic webinars. We try to do this every year, and so we're kicking off and hosting a series of 4 RHC webinars throughout the summer months. Today, Jonathan is joining us with the RHC Best Practice Checklist regarding financial and operational strategies, performance strategies. These webinars that are selected for this cohort or for this group of 4, if you recall, months ago, we had sent out a survey asking you to rank which ones were most of interest or most beneficial to you. And these were the 4 that came to the top. So we are a smaller group. We will be recording this and putting this on our YouTube channel. But as always, please feel free to unmute your line or put something in the chat if you have a question or comment or anything. If you're watching the recorded session, if you have any questions, please feel free to reach out to me. With that said, Jonathan, I'll turn it over to you.
Thanks, Laura. So as Laura had mentioned, really what we're doing is kicking off the first part of this webinar series. And again, the goal is really to provide actionable and tangible information that you can take and really use this as a way to drive performance improvement with your clinic. Now, the goal is to provide you with that information that you can take back and really leverage that going forward. Now, when we talk about the Rural Health Clinic program, again, there's been a ton of changes over the past couple of years and really how we can continue to provide services and remain solvent going forward. Now, oftentimes when we end up looking at whether it's a rural health clinic, a critical access hospital, an independent clinic, whatever the case may be, we very much get focused in much of the day-to-day processes of everything that's going on, that oftentimes we tend to overlook different opportunities or different ways that we can truly optimize within that current environment. So as we talk through today, very much the things that we're going to be looking at today are how we can look at starting to optimize and continue to get back to some state of normalness. Now, again, throughout the COVID pandemic, and you may have heard Laura and I talking about this a few moments ago, as we talk about the COVID pandemic and everything that happened, during the middle of the pandemic, there was a substantive change to the RHC reimbursement methodology. Now, again, I've presented on this multiple times in Oklahoma, but I'm going to spend a couple moments just walking through it again. And the reason for that are these changes are things that are going to materially impact going forward how we can continue to provide access to care, receive reimbursements for the services that we provide, and ultimately impact additional services that we can provide within that rural health clinic, whether we get into care management services, whether we get into some type of PCMH methodology, whatever those instances may be, the reimbursement methodology will have an impact on that going forward. Now, as a part of the Consolidated Appropriations Act of 2021, there was a fundamental change in the reimbursement methodology going forward. And it impacted not only our provider-based rural health clinics, but our independent rural health clinics and our rural health clinics owned and operated by hospitals with 50 or greater beds. So this was a substantive change that impacted every rural health clinic across the country. It's not something that only impacted one of those segments. Now, the first major change as a part of that law that ended up being implemented on April 1st of 2021 is it established a new upper payment limit for all RHCs going forward that are subject to that national upper payment limit. Now, prior to the change in the law, the upper payment limit used to be about an $87 rate. Now, on April 1st of 2021, that rate ended up increasing to $100. So again, it gained about a $13 increase. In 2022, it was $113. This year, it's $126, trending forward to $190 in 2028. Now, each year thereafter that, it'll increase by the Medicare Economic Index. Now, when we think about this to this degree, if we were looking a few years ago at an $87 rate for those independent RHCs and RHCs owned and operated by hospitals with 50 or more beds, going to $190 is a more than doubling of that rate, which will again open the door for many opportunities going forward. Now, in addition to that, another part of this law is it also stated that any RHC that was established after 12/31/2020, didn't matter if you're an independent RHC, a provider-based RHC owned and operated by a hospital with greater than 50 beds, or a critical access hospital or any hospital with fewer than 50 beds, all new RHCs established after 12/31/2020 are subject to those new upper payment limits. Now, in addition to that, the law also established a grandfathering provision. Now, in that provision, it stated that any RHC that was established, owned, and operated by or on 12/31/2020, or if you had filed an 855A to become an RHC on or by that date, you would then be qualified for that grandfathering provision. And that grandfathering provision established your RHC rate based on your 2020 reconciled cost report within that year. And if you were not established by that year, it would use your first established cost report for that year. Now, one thing I want to emphasize that is particularly important for all of our RHCs that are provider-based that qualified for that grandfathering provision, you want to evaluate the rate that was used established for your RHC based on that 2020 cost report. I've seen countless RHCs that have been provided the wrong rate from either their MAC or they've used the wrong rate on their cost report. You want to validate to ensure that your starting point was based on that 2020 cost report year that was then trended forward based on the MEI. The reason that this is extremely important is because that 2020 rate is the starting point that will then be trended forward hereafter and used as that upper payment limit going forward. So again, let's say your reconciled rate was $200 and the MAC sent you a letter for $180. We do not want to be locked in forever at a starting point that was $20 less than what it should have been. So again, we want to take this into account and we want to factor this going forward. Now, when we talk about the RHC methodology going forward, it's important to note that it wasn't only a rate differential that changed. For some RHCs, those provider-based RHCs owned and operated by hospitals with fewer than 50 beds, it was truly a change in the methodology itself going forward. And the slide up here now does a great job of visually representing what ended up happening going forward. Now, if you were an independent RHC, again, your methodology did not change. The only thing that changed was the upper payment limits itself. Again, if we had trended for that $87 rate, maybe this year it'd be $90 in the old methodology versus the $126 it is now. But again, that is an upper payment limit we are subject to. If you were a provider-based RHC owned and operated by a hospital with 50 or greater beds, again, the methodology is exactly the same. The only difference is the upper payment limit increased to that $123 or $126 this year. If you are a provider-based RHC owned and operated by a hospital with fewer than 50 beds, this is truly in the methodology itself. Prior to the passing of the law, you used to receive uncapped cost-based reimbursement. If your cost-based rate was $500, you got $500. If it was $200, you got $200. It always retitrated every year based on the proportion and the allocatable cost that was then determined based on the visits within that rural health clinic. So those not grandfathered RHCs, again, established after 12/31/2020 or had not applied by that date, are now all subject to an all-inclusive capped rate at the national limit. Again, the same as everybody else. Those grandfathered RHCs, again, enrolled in the program prior to 12/31 or on 12/31/2020 or had applied, are now subject, again, to an upper payment limit, but that upper payment limit is capped and trended forward based on your 2020 all-inclusive rate. Now, this is truly a change in the methodology itself. Now, from a best practice approach and how we are going to operationalize this is as we start looking at budgets and as we start calculating financial performance and how all of those things roll forward, we have to pay attention to that upper payment limit, and we have to ensure that we project forward based on that factor. Again, we can't continue to budget based on a true cost-based rate. Now, when we also think about this from a best practice approach, again, looking at all RHCs going forward, think of this in a similar way as really an at-risk model for the RHC program, kind of similar to an at-risk program for your ACOs. Again, if we reduce our cost per unit of service, again, we can stay under that upper payment threshold. But again, if our cost per unit of service continues to increase at a rate greater than the MEI, we are now at risk and will not receive those reimbursements that are in excess of the MEI going forward from Medicare. So again, a completely different approach as we look at the RHC reimbursement methodology. Now, I talked a moment ago about the Medicare Economic Index. Now, as we continue to look forward, our upper payment limit will trend forward based on the Medicare Economic Index. Again, for the independents and those new RHCs, it's set each year through 2028, so that will be the upper payment limit. But after 2028, all rural health clinics will be subject to the same Medicare Economic Index going forward. Now, when we look at that Medicare Economic Index, again, going all the way back to 2014, trending forward to 2023, over that 10-year period, we could see the range has been anywhere from a 0.8% increase to a 3.8% increase, for an average of a 1.6% increase over that 10-year period. Now, even if we look back over that 10-year period, has anybody been able to maintain a 1.4, a 1.6, or even a 2% cost increase over the 10-year period? And the answer is no. Every rural health clinic across the country has experienced an annual increase that has outpaced what the MEI is. So again, it's putting us in a position where we are going to continue to experience cost increases that is going to outpace the level of reimbursements that we get going forward. Again, looking just at those core services going forward. Now, one thing I want to emphasize as we look at the different services going forward, and you'll hear me mention this a couple times through the presentation, the solver for most of our problems within the rural health clinic is volume. Again, because there is a direct correlation between our expense structure and the volume we have in our clinic, which ultimately then goes to determine that cost-based rate or that cost per unit of service, how we are going to stay below that upper payment threshold is to continue to drive volume to our clinic so that we can continue to dilute down our cost per unit of service. This is the quickest or most effective way to stay under that upper payment threshold. And the way it really works out is, let's say our upper payment limit right now is $200. We're a grandfathered rural health clinic, and we have a $200 rate, and we have 4,000 visits within that clinic. If we're able to increase our visits to 8,000, again, I'm just using this for simple math purposes, our cost per unit of service, again, if we were to assume no variable cost increases and so forth, would go from $200 to $100. Again, we are now significantly below that upper payment limit. So as we continue to experience cost increases, and the reason why I'm really bringing this up to such degree is, as we continue to experience cost increases within our rural health clinics, oftentimes we'll see systems or entities try to pull out volume as a way to try to mitigate or control cost, or to redirect patients to other less costly areas. This will not work in a rural health clinic. It will only cause us to experience an increase in the cost per unit of service because of the significant fixed costs that we have within that rural health clinic. So again, as we continue to look forward, we have to find opportunities to pull cost out or find a way to drive volume to that clinic as a way to continue to improve our position. Now, as we talk about the rural landscape and really what we've experienced over the past few years, particularly coming through the COVID pandemic and hopefully forward as we've continued to see a sunsetting of that event, we've all continued to experience staffing shortages, revenue cycle, policy changes, cost increases. Many of us have had to bring in traveler nurses or locum providers or pay a substantive amount increase to maintain MAs and support staff, or supply increase costs. All of those different things are stacking us in a position where we are going to continue to experience those cost increases. What we have to look at, we have to take a proactive approach as a means to start to drive performance improvement going forward. Again, we have to look at those revenue opportunities to really improve our position. Now, when we talk about those additional revenue opportunities, and we really start to talk about from a performance improvement approach, we cannot only look at the core services that we provide within our rural health clinic. Again, our 99213s, 4s, 5s, 17,000 lesion removals, or other things to that degree. We have to start looking at additional revenue opportunities going forward. Again, are we doing our chronic care management? Are we doing our TCF or BHI? Have we integrated behavioral health services into our rural health clinic? Have we started partnering with other area providers? Are we doing swing bed services out of our rural health clinic? Have we partnered with nursing homes to provide those services out of our rural health clinic? Again, start to look at those additional opportunities and start to focus more on the revenue gains versus the expense reductions. It's very important to note that as a rural health clinic, we cannot cut our way to financial solvency. Again, we have core operating costs. We have our lease cost or depreciation cost. We have provider costs, support staff costs. Just to open our door every single day, we have a fixed amount of cost within that rural health clinic. We cannot cut our way to success. Now, in the inverse of that, I also want to emphasize too that even though we can't cut our way to success, we still have to be effective and efficient and financial stewards for the cost within our rural health clinic. We cannot spend unnecessarily looking forward. Now, when we talk about all these programs and we talk about the services, everything ultimately rolls back to the value to the community. Now, when we talk about the value to the community, there's really two ways to drive that. We have our strategy side and our operations side. Now, the strategy is very much focused on how are we going to deliver services, what's our strategic approach, what type of patients do we want to target, the services offered, and so forth. Now, one thing I want to emphasize is there is often a disconnect between broader strategy and the ability to operationalize those components, particularly in small providers, whether it's rural health clinics, critical access hospitals, and so forth. As we start to move in that direction, we have to ensure that any broader strategy that we establish for our organization can be operationalized and can be done so in a financially advantageous way going forward. Again, we cannot position ourselves in a lost position and be able to sustain that going forward. Now, as we start to drill down on the operational components, one of the most important things that I want to emphasize is the convergence or the importance of merging and bringing together financial and quality improvement. Now, if we look at going back into history and we started to look at performance improvement opportunities, quality improvement, revenue cycle, and finance, when we went back to the 80s and 90s and so forth, were very much segmented and operated as separate, distinct components within the healthcare environment. As we continue to look forward, we have to start to realize that merging those areas going forward will be extremely important. Now, when we started to get to the 90s to 2000, there really wasn't much change. Quality assurance changed to quality improvement, but it was still very much segmented and siloed. It wasn't until we got to the year 2000 that we saw broad change across the industry, where we saw a merging of revenue cycle and finance, because we realized that revenue cycle, claims conversion, collection, payer contracts, all of those things had a direct impact on financial performance. So what we had to do was we had to merge those together into a single performance improvement collective as a means to drive that going forward. But we still saw a segmenting or that siloing of quality improvement. In today's times, our top performing organizations have really come together, realizing that in today's times, quality has a direct impact on financial performance, and financial performance has a direct impact on the ability to provide and focus on quality initiatives. We have to come together as a single performance improvement collective. Now, I'll give you an example. I was at a hospital a while ago, and I ended up going in and having a conversation with the quality improvement side and the performance improvement side relative to revenue cycle. And when I was working with this organization, I had them give me all of their metrics that they were tracking. And when I drilled down into those different metrics, I saw an example of where if the quality improvement initiative was able to complete their metric, the financial side would not have met their metric. And vice versa. If the financial side, revenue cycle side had met their metric, quality side would have never had the financial resources to meet their metric. So again, we have to come together and realize the direct impact on those sides, especially as we start to move towards different population-based initiatives, whether it's PCMH, whether we're in an ACO, whether we're performing in any of those different areas. To be successful in any of those initiatives going forward, we have to realize the direct linkage between financial performance and quality improvement in today's times. Now, the next area to focus on really around our different practices is to say we have to continue to evaluate the alignment and designation of our practices to ensure that they are established in a way that's effective and in a way that is optimizing reimbursements that we receive for the services that we provide. Now, as we continue to look at those designation strategies, we cannot assume a one-size-fits-all approach is applicable for all practices. Even if we are a three-practice individual group or we are a multi-practice system that owns and operates several practices throughout the region, we have to take those factors into account when we evaluate our practices going forward. One practice may be best as a provider-based clinic, one practice may be best as a rural health clinic, and one practice may not meet any of the designation criteria and have to operate as a freestanding clinic. Now, in addition to that, what I also want to emphasize is because our cost structures, our volume, the services that we provide continue to change, we also have to realize that as time goes on, the optimal designation itself may also change going forward. Now, there's four main strategies that we should be continuing to ask ourselves and evaluate as we continue to look at our practices going forward. Now, the first strategy is continue to evaluate and convert practices to a designation that would improve the net financial position of that practice. Maybe we're a freestanding clinic right now, an independent practice that operates as a freestanding clinic. Due to the new RHC reimbursement methodology, is it more advantageous to be an RHC? Maybe we're a rural health clinic and we're under a critical access hospital and our cost structure continues to rise. Maybe we want to convert that to a provider-based clinic. Again, we want to look at all of these opportunities. The next strategy is really for those that operate within a system environment. We must evaluate and establish a system strategy that looks at the regional deployment of practices in a way that leverages the different reimbursement methodologies. If we were to go back 10 years, or even a lot of larger systems in recent times, they have a single physician group that's an owned and operated subsidiary under that hospital entity system that then operates kind of like a distinct unit similar to your hospitals and other business units under that system. We have to evaluate the alignment and designation of those practices. Again, putting them under a critical access hospital could allow us to qualify for 340B or get enhanced reimbursement rates. Again, we want to look at things to that degree. The next strategy is around consolidating or integrating specialty providers and practices into designations that may lead to more advantageous reimbursements. For instance, the fact that this year independent RHCs have a $126 upper payment limit and it's trending forward to $190. In the past, under an $87 upper payment limit rate, it did not make sense potentially to integrate maybe an orthopedic surgeon or a dermatologist into our RHC one day a month or a couple days a month or one day a week. However, going forward with that upper payment limit, we can now sustain and start to bring in specialty providers into that rural health clinic going forward. So again, it opens the door for different alignment opportunities. The same thing for our provider-based rural health clinics. Again, integrating that provider in can allow you to gain access to 340B, can allow you to gain access to other reimbursement opportunities. The last strategy, again, is really around the acquisition of different practices. Again, realizing that in today's times, there are still certain advantages afforded to provider-based clinics. The ability to qualify for 340B if the hospital qualifies, the ability to get enhanced rates, operational efficiencies, payer contracting opportunities. Again, continue to look at these opportunities. There is no one-size-fits-all. I want to reemphasize that. What works for one clinic may be the opposite for another clinic. Now, as we continue to look forward and we look at those performance improvement opportunities, it's important to segment them out. Now, again, I broke them up into four different quadrants: operating, financial, market, and value. You as organizations can segment them in any way that works for you, but it's important to break them up into different functional areas or different applicable areas to ensure that you are addressing all of the different areas across your organization. Again, oftentimes we'll see organizations just focus on financial or just focus on operating. Now, when we talk about those performance improvement initiatives, it's important to select both micro and macro metrics. And it's important to also select things in different quadrants to ensure that we're evaluating the performance, the overall performance of the organization, but also ensuring that we can drill down at a granular level as necessary and also stay at that broader health level. And I'll give you an example of this. Oftentimes we'll go into a rural health clinic, and one of the metrics that they'll track is net days AR. Now, again, net days AR is a great metric to track when you want to look at the overall performance of your revenue cycle department, but it doesn't allow you to drill down to any one particular area. Again, there's 1,000 things that go into net days AR: claim ratios, first pass, conversion rates, self-pay, all of these additional things. Even the ability to operationalize things such as point of service collections or getting insurance cards, and all of those different things can substantively impact your net days AR. So again, we want to focus on not only net days AR, but we may also want to focus on DNFB or DNFC as an ability to drive broader performance improvement. So again, take all of these things into account. Another thing I also want to emphasize too is don't continue to focus on the same metric for 10, 20 years. You want to continue to change what you're focusing on. One, it removes and creates some variability so you can start to drill into different areas, but it also ensures that you continue to elevate performance improvement initiatives. Oftentimes we've gone into organizations where they'll focus on the same metric. And again, eventually, because you're tracking the same metric over and over and over again, it tends to lose its import from a tracking approach. We want to continue to look at these things going forward. Now, one of the most important things I would also say we want to focus on, particularly from a best practice approach for our rural health clinics, is we really have to start focusing on practice management. Again, that broader practice management approach of looking at how is the practice driving as a whole, and what are the different functional areas that are ultimately dictating the overall performance within that practice. And oftentimes we see a segmenting within the practice within our rural health clinic. Again, the providers tend to be in one standard. We have a practice manager that's only responsible for certain performance outcomes and so forth. We have to identify a single person within each practice that's responsible for the broader performance of that practice. Now, again, even in an independent clinic where the owner is a provider itself, that practice still has to have a practice manager that has a visual idea of what is going on within that practice. Yes, not to say the practice manager can terminate that provider and so forth, but again, there has to be somebody that understands the broader performance of that practice that can drive initiatives going forward. We also have to understand that we have to start establishing dashboards to truly track performance improvement going forward. Again, what we can't focus on is all of the fires that we go from day to day to day. We have to have some type of optics into the broader performance improvement. Now, when we're talking about a rural health clinic, again, that broader performance improvement, one of the areas I would focus on really, if we're tracking nothing right now, one of the things I would track right now is our productivity threshold, so the number of visits per provider within our rural health clinic. Again, are we achieving minimum productivity thresholds? What is our throughput times? Again, look at things to that degree as a basis of starting to dabble within how we want to track and evaluate our rural health clinics going forward. Now, I talked earlier about financial performance and so forth, and I talked about our cost structure as a rural health clinic. Now, operating within a rural health clinic, we have to realize that upwards of 90% of our cost within a rural health clinic is fixed, and really only 10% is variable. Now, what this means is it doesn't matter whether we have 2,000 visits or 5,000 visits. That 90% of our fixed cost is probably going to remain the same. We are not going to see any differences. Again, whether we have 1,000 patients or 2,000 patients, we still need one provider. We still need an MA. We still need a front office staff person. We still need to pay our facility cost, electricity, and all of those different factors. That cost, again, is not going to change. Only 10% of our cost is truly variable. And that's the incremental supplies that we buy as we deal with patients. Again, it could be the gloves, it could be any things that we have within the patient rooms, our gauze, all of those additional supplies that we use. It is also that incremental staff that we have to bring on as our volumes end up increasing past a point where we can no longer sustain those services with the staff that we have. But again, 90% of our cost is fixed. So as I emphasized earlier, from a best practice approach, this means we cannot cut our way to success. We have to start driving volume going forward. Now, the next area to focus on is really our charge structure as a rural health clinic. Now, as a rural health clinic, what ends up happening for our Medicare population is 20% of the charge is passed on to that beneficiary as a way of the coinsurance deductible for receiving care. So when we are establishing our price list as a rural health clinic, we have to ensure that our price list is defensible and established in a way that does not put us at a competitive disadvantage to other providers of care. Now, let's take, for instance, let's see that we are a rural health clinic and we end up charging $300 for a 99213. Now, what's going to happen for that Medicare patient is they're going to be assessed a $60 payment for that service, with that charge being at that 99213 at $300. Now, if you were to compare that to another clinic, a non-RHC, where even if they charge the same $300, they have an established or fixed coinsurance because of that methodology itself. So again, as we establish our pricing methodology, we have to ensure we don't do so in a disadvantageous way. We will pass on a significant portion of the cost of providing service due to the fact of how that RHC charge is established. So again, establish a price list that is effective and defensible going forward. Now, the next area we want to talk about is our providers. Our providers is the most significant cost that we will incur often within a rural health clinic. Again, we may have an APP that we're paying $120,000 or a physician that we're paying $200,000, $250,000 a year for the cost to provide care. It is a significant cost that we incur. What we have to start evaluating is truly assessing our provider complement. And that provider complement is not only the providers that we employ or that we contract with. As we continue to evaluate our primary and secondary services and service area, we have to have an understanding of the providers that are providing services in our service area, even those providers that are not directly affiliated with our organization. Now, what we have to get away from is what I really call the Field of Dreams methodology of the if you build it, they will come approach. We cannot do that in today's times. Again, we are continuing to see increased competition and an increased delivery of services out there, particularly because there is an increase of telehealth type services. So as we continue to evaluate the need and demand for services within our community, we have to understand all of the providers, not only within our own entity, but the other providers within our service area that are providing services going forward. It can impact the ability to get additional HIPSAs or maintain HIPSAs. It can impact the ability to bring in providers or to be able to maintain profitability going forward. Again, we have to evaluate all of those services. What we also have to look at is hopefully all of us are doing our fair market assessments and Stark analysis if it's applicable and so forth relative to the delivery of services. We have to ensure that we are compensating providers effectively going forward. We have to really get away from a fixed just salary compensation or a 100% work RVU driven production type service. We have to continue to evaluate services going forward and to ensure that we're remaining competitive in that environment. Now, when we talk about the productivity of our providers going forward, it's important to note that when we look at rural health clinics, there is that core standard, that productivity threshold for those RHCs. And again, for every one physician FTE worked for a physician, it's 4,200 visits. For every one FTE worked for an APP, it's 2,100 visits per that APP. Now, again, when we talk about the FTE calculation, it's important to note that there is no provider that works a 1 FTE within a rural health clinic. Again, you have to carve out your vacation, your sick time, any time that they're doing administrative, non-scheduled work within that clinic. Only the time that they're scheduled to see patients within that rural health clinic counts as the FTE calculation for that minimum productivity threshold. Now, we compare a 1 FTE physician to that 4,200 visits and the 2,100 for an APP. If they were not achieving these thresholds, they are nowhere near a high-performing provider in that setting. Now, again, if we were to compare 4,200 visits for a physician and 2,100 visits for an APP, the physician comes out to 16 patients, roughly 16 patient visits per day, and the APP comes out at roughly 8 patient visits per day. If we were to compare this to the NGMA benchmark for productivity, only seeing 16 patients per day would put you roughly at the 25th percentile of productivity threshold. So again, if our providers are not even achieving that minimum productivity threshold, and again, there were tons of clinics across the country that did not achieve that minimum productivity threshold, we are not even in the 20th percentile of productivity for those different providers. So again, there is the ability to increase performance going forward. Now, one thing I also want to emphasize too is if we have providers that are not achieving those minimum productivity thresholds, we also have to look at additional opportunities to reduce administrative burden or create efficiencies within the work that they are doing. What we can't do is continue to push on our providers and say, you need to see more patients without addressing EHR issues, without addressing throughput issues. If we have one provider that only has 1 or 2 exam rooms, it's going to be hard for them to truly turn a significant number of patients if they are limited in their setting and in their ability to provide services. Again, so evaluate those operational issues that could be preventing those providers from seeing a significant number of patients. The next area is really around provider contracts. Now, again, as we talk through these opportunities today, I'm really given a 20,000-foot view of different best practices because we're going to start to drill into a lot of these areas into a much more granular fashion in the upcoming presentation. But I really wanted to start getting us thinking about different functional areas and different operational components. Now, when we talk about provider contracts, again, most rural providers are still establishing a significant portion of their contracts based on a fixed salary and some type of work RVU production bonus. As we continue to move forward in a population-based initiative or focusing on value-based care or anything in those initiatives, we have to realize we have to start changing our provider contracts going forward. Now, again, best practice provider contracts in today's times has a base salary, a work RVU bonus. They also have incentives that are focused on panel size, quality scores, and patient satisfaction scores. Again, the reason for this is if we are focused on 100% work RVU as a production bonus standpoint, we cannot push our providers, or our providers would be less willing to focus on population-based initiatives if they are compensated based on the number of patients that they see. On the inverse of that, again, if we are compensating our providers solely on quality scores and we are not compensating them anything on the number of visits that they see, it's going to be hard to get our providers to start seeing more patients if everything is driven on satisfaction and quality scores. Same thing, again, as we start to look at panel sizes, again, when we look at the attribution of lives and so forth, building in panel sizes will start to get more patients attributed to our providers. That again, if we start focusing on those wellness visits or the annual wellness visits or other things to that degree, that will increase the number of visits throughout the year, but it will also start to get more patients attributed to our providers. So again, we have to start looking at these as an opportunity and as a way to drive compensation going forward. Now, next, we're going to drill into cost report, and this is probably everybody's favorite topic on this webinar today. Now, when we look at the cost report, we have to realize the cost report is not merely an administrative task that is completed once a year that really drives things for our rural health clinic. We have to realize that the cost report itself is an operational document that has a direct impact on the reimbursements that we receive as a rural health clinic. Now, I always like to say that when we have an effective cost report, we've really looked at merging the art and science of cost report preparation, realizing that the science side is really like, where do we put the numbers? Do we put the right FTE here and so forth? The art side is really operationalizing the cost report and realizing where providers are going and the services that we're providing and how we're stepping down costs, and all of those different factors has a direct impact on the reimbursements that we receive. So what we have to start looking at is saying, how can we operationalize the cost report, and how can we start looking at that as a means to drive things going forward? Now, when we look at it to that degree, again, start to evaluate the cost report and start drilling into those areas as a means to continue looking at it going forward. Do not look at it just as an administrative task. Again, it will impact our reimbursements. It will look at those things going forward. Probably the biggest opportunity for our rural health clinics is looking at the FTE calculation used for determining that minimum productivity threshold. Again, the overstatement of the FTE could lead to us failing to achieve that minimum productivity threshold, which could reduce our reimbursement rates going forward. Now, when we talk about quality measurement, and again, I talked about this a little bit earlier, what we really want to look at from a quality measurement is we want to focus on different measure types. Again, structural measures, process measures, outcome measures, and composite measures. All of these different areas will allow us to drill into different ways that not only allow us to evaluate the outcomes for our patients, but also the effectiveness of services, the financial cost associated with those services, and all of those different factors. Now, I know all of you have access to, I believe, Pond and LilyPad and so forth as the ability to evaluate different things. I would highly suggest that you leverage these tools as a way to drive and evaluate either quality outcomes or financial performance for your clinics. Now, the next area is really around revenue cycle. Now, I'd say revenue cycle, again, is one of large opportunities for many rural health clinics. And I would say it's one of the areas where we are leaving significant amount of dollars on the table. Now, when we talk about revenue cycle, most organizations view revenue cycle from the claim life cycle. Again, from the patient leaving the clinic until you actually get your claim paid and converted and adjudicated and so forth. Now, what I will say is revenue cycle starts long before the patient ever shows up at your clinic. And some of the most important areas to focus on is contract negotiation, your fee schedule, your EDI transition process and clearinghouses, your provider enrollment. All of those areas, if you focus on those areas and you can get them cleaned up on the front end, you will save yourself an exponential amount of time on the back end. Again, same thing when we start getting into some of those pre-registration and registration functions. Just reaching out when a patient comes in and confirming every single time they come in relative to their insurance and confirming their insurance card will improve your position going forward. So again, we want to evaluate that going forward. And again, looking at all of those different factors. Point of service collections is another significant opportunity as we continue to look. Are we collecting money from our patients, and are we looking at that as a means going forward? Now, the last area is really around additional opportunities. We have to leverage data within our rural health clinic, and we have to start looking at additional revenue opportunities as a way to sustain and bring in additional revenue for our facility going forward. Now, when we look at those areas going forward, we have to take this into account and realize that getting chronic care management, transitional care management, we want to increase the number of patients that are accessing care within our clinic and using that as a way to go forward. Have we expanded behavioral health services? Have we looked at all of those additional opportunities? Now, again, I know I went through a lot of this information very much at a 50,000-foot view. And again, the goal was really to identify different opportunities and really lay the framework for additional conversations. I'm going to pause now to see if there's any questions that maybe I can answer around any of the information that we went over today.
Hey, Jonathan, I'm not seeing anything come up in the chat right now. I did want to take a moment and look ahead to our next scheduled webinar, which is June 27th at noon. we'll actually be talking about revenue cycle during that call. So just one last chance if anyone has any questions or comments. All right. Well, Jonathan, thank you for your time today.
Thank you very much. And again, if you do have questions, I mean, Laura is a great resource. So reach out to Laura if you have questions, reach out to me. You have a lot of great resources available. As you continue to, incur these different questions or you continue to hit different situations, please reach out. Again, we want to ensure that you're put in a position to be successful going forward.
Absolutely. And as you leave this call, if you think of something, please don't hesitate to reach out. If I don't know the answer, which is very likely, I will follow up with Jonathan or one of our other colleagues. So again, thank you all for your time.
Thanks all.